So we will be starting our last session, which is, always there is a debate which test is better, whether it's a nuclear medicine or whether it's a cardiac MR. So I would like to, so as a chairperson, I would like to invite Dr. Guna Seelan. So he is the consultant cardiothoracic and vascular surgeon working at KMCH. He has completed his MCH from the prestigious Sri Jayadeva Institute of Cardiovascular Science and Research. From the IACI faculty, I welcome you, sir. Please have a seat. I would like to call on Dr. Shivabal. He is an assistant professor and consultant intervention cardiologist working in KMCH. I think he hasn't. I think he hasn't come. Okay. So, with the permission of chairperson, I would like to invite Dr. for the talk on nuclear medicine, Dr. Kamaleshwaran. He will be talking about myocardial viability assessment using nuclear scintigraphy.
Yeah, I'll see here. So, good afternoon, everyone. So, I thank Dr. Pudiyavan and IACI for giving this opportunity. Mainly, with last day post-lunch session. So, like debate, it's a debate where everywhere we say nuclear medicine is best and radiology is best. So, this debate will be on myocardial viability, which is the least used in nuclear medicine. So, mainly I will be talking about supporting SPECT and PET. So, the concept of hibernating myocardium was first proposed by Dr. George Diamond in 1978 and it was popularized by Dr. Shahabuddin in 1989. So, the main differentiating between viable hibernating myocardium and non-viable scar tissue is the most important before any revascularization or CABG. So, nuclear medicine it plays a role in detecting this viable hibernating myocardium. So you can see this the myocardial ischemia. If it is acute, it will cause stunning, and if it repeated stunning, it will go to that hibernating myocardium thing. So this metabolic adaptation will happen in hibernating myocardium. This metabolic adaptation is the one which we image with SPECT and PET. So these are the modalities available for myocardial viability assessment, mainly echo, SPECT, PET, MRI, and cardiac CT. So why SPECT and PET is needed? Because echo and CMR provides only an indirect evidence of the existence of living but suboptimally functioning cardiomyocytes. To provide direct evidence of to see visually that the tissue is viable or not, SPECT and PET it plays a main role. So to see the direct evidence, molecular imaging is warranted. So what is SPECT? SPECT, we know it is a single photon emission. We use technetium in that. The principle is active and passive transport of the molecule over the cell membrane. So if the radio tracer is injected and it goes into the tissue, that means it is viable. So if we see the uptake in the myocardium, then we say it is viable. So, but SPECT main thing is if there is no uptake in perfusion, then we do a FDG PET CT which will show the hibernating viable myocardium. And in SPECT, fasting is not compulsory. So this is our KMCH SPECT CT machine which we have for last 13 years. So we image technetium with the 140 kV gamma photon. You can see this is a dual detector camera and it is a open gantry. So the claustrophobia thing won't be there in this imaging. So this is the SPECT imaging of a cardiac patient. You can see patient lying down and ECG leads are connected and we see wall motion and ejection fraction and gating with the help of SPECT CT perfusion. So the camera rotates around the patient for 180 degree and myocardial imaging will be performed. So thallium 201 is the one which we were using in the old times like it is a potassium analog and it is transported into the cell with the help of sodium iodide, sodium potassium transporter. So the main thing with the thallium is high radiation dose, and because of poor image resolution, it was actually the last 10 years before it was used, but now at the present PET and other things are available. Thallium is outdated, and it is not available also, and it is not used nowadays. So I will not go into that. So I'll be talking about mainly technetium sestamibi, which is the MIBI, methoxy isobutyl isonitrile. The mechanism of entry into the cell is passively it enters into the cell and it goes into the mitochondrium and fixes in the mitochondrium of the cardiomyocytes. So if we image, then we will see the perfusion is present or not. So it is a good marker of myocardial perfusion, and it is used to assess the ischemia. So MIBI is mainly used in seeing ischemia, and also in we can use it for viability assessment. So it is mainly used in many clinical trials and routine clinical practice also. MIBI is the most commonly used. We use in KMCH also mainly MIBI. With the same mechanism, the another radio tracer is available, which is called technetium tetrophosphine. So this is the images. You have to know what are these images. So if we image the patient after injecting sestamibi, you can see the myocardium, which is this is called planar image. So you can see the myocardium, and MIBI is excreted in the liver through biliary excretion. So you can see liver and bowel activity. So we use a 17 segment model, and this is the cardiac SPECT CT image. You can see the myocardium registered to the MIBI uptake registered to the myocardium. So we use CT mainly for attenuation correction. So this is an attenuation corrected CT used in SPECT CT. You can see this is the 3D wall motion image. You can see all the anterior, lateral, inferior, and septum, and we can see the wall motion abnormality also in this. This is the myocardial normal perfusion image. You can see anterior wall, inferior wall, septum, and lateral wall. And this is called polar map. We can see the polar map with reconstruction of this axial images. So this is the short axis image, and this is the horizontal axis, and this is the vertical axis. You can see the reduced perfusion noted in the inferolateral wall. So this is reduced perfusion area. So there are dedicated cameras are also available with the cardiac SPECT, which are available in many cardiac centers. So with this, the patient can sit and we can image the patient. And with the help of this, we can do a dynamic study and see myocardial flow reserve also with the help of this cardiac SPECT camera. So what are the disadvantage of SPECT? SPECT, because if there is an absence of tracer uptake in the myocardium, it does not confirm a non-viability, because even it can be viable, perfusion absent, and still it can be viable. And another thing, poor resolution. Because of poor resolution, sometimes we can say thin viable myocardium as non-viable. So another thing is more radiation exposure than PET. So this is one of the disadvantage of SPECT. So this is our KMCH PET CT, which we installed 2 years before. So like SPECT perfusion, PET perfusion tracers also now available. And the main thing is we have a good resolution with the PET machine, and less radiation than the SPECT. So what are the viable perfusion PET tracers which are available and most commonly used in most of the centers around the world? But in India it is not much used, because you can see the 3 perfusion tracers which we image with PET is oxygen, ammonia, and rubidium. You can see the half-life of these tracers are very minimal. Like rubidium is only 76 seconds and the oxygen is 2 minutes. So because of the low, very short half-life, there should be an on-site cyclotron to have this tracer, and we have to inject the tracer immediately before the half-life goes off. So this is one of the disadvantage of PET perfusion tracer, but this is used mainly in very rarely in centers like on-site cyclotron is available. But it shows a good superior images, and sensitivity is more with the PET perfusion tracers. So, but these are not commonly available. So we mostly use SPECT MIBI. So coming to FDG PET is the most sensitive imaging method for detecting viable hibernating myocardium. Even it is considered as a gold standard for viability. But main thing is this FDG PET CT. Imaging is very easy, but preparing the patient to image is the most time-consuming protocol, where we give glucose loading and insulin to the patient to increase the diagnostic accuracy. Because in fasting patients, we see myocardial uptake will be variable because in fasting patient, fatty acids will be used most commonly. This is an example image of the patient. You can see for an oncology patient, we did a PET CT of this patient. You can see in this patient fasting, there is no myocardial uptake, but in this patient, there is a myocardial uptake. So the myocardial uptake will be variable even in fasting patients. So in order to increase the myocardial uptake and see the hibernating myocardium, we have to give oral glucose loading, and to increase the insulin level. With the help of increased insulin, the fatty acids will be suppressed and myocardium will uptake the glucose, and we image the hibernating myocardium. And in FDG PET CT, fasting is necessary, and a patient comes fasting, and in diabetic patient we give glucose, then insulin IV, then decrease the glucose level and inject FDG and do the imaging. Hyperinsulinic euglycemic clamp protocol is the most standard protocol, but it is not followed in most of the centers because it is very time consuming and difficult compared to oral and oral glucose loading. So this is the metabolic preparation period which we do in our department if patient comes to our department in the morning fasting. So you can use either dextrose also IV or oral glucose loading also you can do, and then inject insulin, then inject FDG and do the imaging. After IV injection of FDG, we wait for 45 to 60 minutes, then do the imaging. FDG image takes only 10 minutes to image. So most of the people ask like, there is no perfusion, then how FDG goes into the hibernating myocardium? So that question is answered in this thing. Like you can see how a hibernating myocardial cell show maintain FDG uptake even though there is no perfusion with the help of MIB. So this is answer like there is no perfusion, but insulin independent to GLUT1 and GLUT3 transporters are there, which have a low Km value. It does not require energy to function. So because of that, the FDG will go into the hibernating myocardium. So if you see, and another thing is FDG we image after 45 minutes. So the FDG which is present in the blood and in the extracellular space, it comes to the hibernating myocardium very slowly, and we can image that. So this is a image. We have to know this image. So you can see perfusion normal. If perfusion is normal, we don't do FDG. But for this is an example image. You can see perfusion normal, metabolism also normal, and this is the match defect. You can see a defect in the apex and adjacent septum, and FDG also showing no uptake. So this is a matched defect. It is a scar tissue. So here, this is the most important thing. You can see the defect in the lateral wall in perfusion, but in FDG it shows good uptake. So this is the perfusion metabolism mismatch, and it is the hibernating viable tissue. So this is the most important thing which we see in imaging with PET. So what is the sensitivity of FDG PET? It has a high sensitivity, that is 92%, but specificity is low, mainly to predict the improvement in LV function after revascularization. And another thing, we have quantitative myocardial blood flow with perfusion tracers. So it helps in additional prognostic information also, and increase the diagnostic accuracy. So which is the best combination of perfusion and PET? We say if ammonia is available, it is the best tracer for perfusion with PET if SPECT is not available. So ammonia and FDG can be done in PET machine. So it is the best available perfusion and metabolism combination. But in centers which are not available ammonia, then we use MIB and FDG. So we use, as I told, that we use 17 segment model, and the score can be given from 0 to 4. You can see mildly reduced in count is score 1, and moderate is 2, severe reduction is 3, and absent count is 2. So we score the 17 segment with the help of this coloring thing. So you can see this green color and blue color areas are areas which are not showing perfusion. So we say these areas are not viable. So we reconstruct and say anterior wall, septum, inferior and lateral wall. So what is the criteria for viability with SPECT? So if the uptake of the tracer is more than 50% of the maximum uptake of the normal segment, then it is called viable. That is score 1 and 2. Score 4, which is uptake less than 30% of the other normal areas of myocardium, is considered as non-viable. So in those cases only we go for FDG. So this is an example image. You can see normal perfusion of the all the segments, and this is the polar map showing good perfusion in all the areas. So we do gating. So you can see the contraction of the walls, anterior, inferior septum and lateral walls, and thickening also we can see with the help of gating. So this is the 3D wall motion of the myocardium. You can see the contraction of the all the walls are normal, and you can see EF also showing 70%. So we can see even end diastolic volume, systolic volume, everything with the help of gating. So this is an image of a maybe showing LAD anterior wall MI and all these green areas. We have scored 4. So these areas are not showing uptake. So we thought it is non-viable, and this is the gating image. You can see the areas which are not showing uptake. There is no thickening also. There is no wall motion also. This is the image of the 3D wall motion. You can see the lateral wall is only contracting, but if you see septum, apex and anterior wall, there is no contraction. So we thought it is non-viable, and even you can see EF is around only 18%. So this is another case. You can see maybe showing this viability. You can see the green area is very less, and around that blue areas and pink areas are there. So this is a mixed viable and non-viable myocardium. So we did FDG in this patient. You can see the septum and the anterior wall showing uptake. So this is a mismatch. So it is a viable myocardium. This is another case. You can see FDG showing severely reduced, like absent perfusion in the apex and adjoining apical segments, and even in the septum. So this is the image, and you can see FDG also showing same thing. So both are matching. So it is a non-viable myocardium. So you can see visually the areas which are not viable. So main thing with the PET is I want to say it has a high negative predictive value. So if there is no uptake, that means it is not at all viable, and if you revascularize, there will be no improvement in EF. So it has a high negative predictive value compared to positive predictive value. So this is another case. You can see maybe showing only minimally absent in the apex. So this is a very small segment. So in this case, there is no need to go for FDG. With maybe perfusion itself, we can say the most of the areas are viable. So they can go for revascularization. In this case, there is no need of doing FDG and wasting time. So this is another case. You can see lateral wall defect. It is showing a score 2, like moderately decreased. So you can say this is viable. In this case also, no need to go for FDG viability. So all cases, it is not necessary to do a FDG viability. So coming to the trials, I will show some 2 to 3 trials. As we all talk about viable myocardium, but still the role of myocardial viability in managing the patients with heart failure is still controversial because of the failure of randomized control trial, which didn't reveal clear benefits of the viability testing. So what is improvement? Like more than 5% improvement in LVF after coronary revascularization, there should be a hibernating myocardium of around 20%. And another thing, if scar is more than 20%, and if segment more than 4% scar, then there is no use of revascularization. So these things are done in most of the RCT trials. This is the landmark trial, which is a stitch trial, surgical treatment for ischemic heart failure. So this trial, the 10-year outcome data was recently published in NEJM in the topic of myocardial viability and long-term outcome in ischemic cardiomyopathy. So the patients who are undergoing CABG and CABG plus medical therapy were randomized with the help of viability assessment into SPECT and echocardiography, and they divided viability patients to undergo medical therapy and viability patient to undergo medical plus CABG in 300 and 300 patients in both arm. So you can see they have done patients with LVF of less than 35, and they follow-up was for 10 years. So in this SPECT was used, and PET-CT was not available that time, so SPECT was used. So what is the result? Result, you can see the CABG plus medical therapy has low incidence of death compared to medical therapy alone. That is the one thing which, but the presence or absence of myocardial viability in the patients who have undergone CABG plus medical therapy or medical therapy, there is no much change. So, but the patients who have myocardial viability, they show an increase in LVF. But irrespective of the treatment assignment, this LVF didn't correlate with the long-term survival. So the stitch trial says that even myocardial viability assessment is done, there is no much change in the patient treatment outcome and death outcome also. But is this trial valid at the present stage of like PET and MRI available? I say it is not at all valid, because that time DSC and SPECT was used, and they have some viable group were included in the non-viable group. So at the present era of PET and MRI, I say this stitch trial is no longer valid. So coming to FDG viability trial, there are some trials which have done with the help of FDG viability, and patient has undergone revascularization. So one of the trial is part 2 trial. This is PET and recovery following revascularization trial, which is published in 2007. They assess the effect of PET assisted revascularization versus standard of care in the preoperative workup when patients who are undergoing revascularization. So they categorized the hibernation score, SCAR score, and various clinical parameters, and they put into a model and predicted the LV recovery. So in this, 430 patients were analyzed, and 218 patients underwent PET assisted revascularization, and they included over a 4-year period. But the overall result and the main outcome, that is cardiovascular death, was insignificant. That is, addition of PET to the preoperative diagnostic workup has no effect on the clinical parameter. This disappointing outcome of the study is mainly quickly led to the methodological criticism, because most of the clinicians were poorly adherent to the PET assisted surgical treatment. Mainly the patients, a high proportion of patients with high or moderate viability with PET did not undergo revascularization. So the part 2 trial, the University of Ottawa Heart Institute, with the help of experienced reader, they took only 111 patients, and they did a separate post-hoc analysis of this patient, and they came to a conclusion that PET assisted decision making had a significantly good outcome compared to the patients with no viability. So this study showed that PET is more useful. So this is another part 2 sub-study where 182 patients were analyzed, and they showed hibernation myocardium of more than 6%. It has a decreased risk of main outcome if revascularization was done. So this is another study. You can see 5% myocardium is necessary to have a revascularization. This is another study. You can see in 648 patients, they analyzed and showed more than 20% hibernating myocardium is necessary for early revascularization to prevent the risk of death. So comparing all these studies, what is the quantity of viable myocardium which is necessary to improve the survival of these patients? There is a meta-analysis which showed PET 25.8% by PET, there should be a viability to go for revascularization to have improvement in LV. And you can see in stress echo, it is around 35%, 36, and SPECT it is 38%. So the separate cutoff values are most helpful in helping the cardiologists and cardiothoracic surgeons to either to decide for revascularization or not. So this is another meta-analysis, like stitch trial and part 2 trial showed there is no benefit. But in 2002, there is a meta-analysis study which they took 24 viability studies in 3,000 patients, and they showed 79.6% reduction in annual mortality in those patients who have viability and they have undergone revascularization. So this is another trial, like we talk about CABG and PCI, but even that Christmas trial where carvedilol is used in those patients in myocardial viability, it showed a very good improvement in EF post-treatment with carvedilol, because this hibernating myocardium is the one which the carvedilol act on it, and it shows an improvement in hibernating myocardium. So even in medical therapy trial also, myocardial viability is most important. So this is a meta-analysis where 158 patients 158 studies were taken, and finally they came to a conclusion PET is having the highest sensitivity and negative predictive value in those patients who are undergoing revascularization in predicting the improvement in LV function. And echo has the highest specificity and positive predictive value. So what is the current guidelines say? So European Society of Cardiology recommend class 2B level of evidence that it may be considered. It may be considered as a non-invasive stress imaging for the evaluation of myocardial viability. And level B evidence, because it has very less RCT trial and multiple meta-analysis trial were there. ACC and AHA guidelines consider that myocardial viability is one of the tool to inform decision, mainly in high surgical risk patient and complex medical problem. So this is the chart which shows, you can see Moderately or severely reduced LVF, if you do ischemic evolution, there is no ischemia, high risk, you go for viability testing with PET or CMR, and if it is viable, go for revascularization, non-viable, go for only medical therapy. SPECT, if it is non-viable, then go for PET or CMR. So coming to the debate part, I didn't get much study comparing MRI and PET, but there are some studies which I will show. 2018 World Journal of Cardiology published the accuracy of myocardial viability by MRI and PET depending on LV function. The conclusion of the study was CMR is less optimistic in functional recovery prediction. So we talk about competition, but nowadays PET MRI is available. So there is a comparison study where PET MRI was used, and they compared the viability assessment with MRI and FDG. FDG PET was better predictor for functional recovery compared to MRI. So this is a comparative analysis of myocardial viability multimodality imaging recently published in 2022. You can see this is the comparison analysis. PET has the highest sensitivity and negative predictive value, and it appears to be more optimistic in functional recovery prediction. So this is a recent trial, revived BCIS2 trial, which the study initial results have been published, but final result is yet to come. It is a prospective trial, 700 patients with LVF less than 35 and viability of more than 4%. They are undergoing revascularization with PCI or medical therapy. So viability testing is mandatory in this trial, and in this trial, I think we will get the main thing which we are expecting, that the relationship between the completeness of the revascularization of the viable myocardium and its subsequent clinical and remodeling outcome will be assessed in this trial. But unfortunately, the initial results are published. You can see PCI failed to provide any additional benefit beyond OMT in patients with severe LV dysfunction, and this additional analysis is yet to come. So again, the concept of myocardial hibernation was challenged with these results, since only patients who are with myocardial viability were enrolled in this trial. So another 2-3 slides. So this is another trial. You can see this is coming up alternative imaging modality in ischemic heart failure project 1. So in this recent modalities, PET and CMR is used to assess the viability instead of SPECT and PET. Sorry, instead of SPECT and echo. This is another trial which is going on, cardiac FDG PET viability registry trial, and patients are recruiting for this trial going on. So I came across this study in Indian Journal of Clinical Cardiology by Dr. Johann Christopher. So what is the advantage? I will talk about only advantage of PET. Metabolic image is relative gold standard. It is highly sensitive to pick up small areas of viability, and I told it is a high negative predictive value, and it predict outcome of revascularization. What is the disadvantage of CMR? Main problem with the metallic implant and cardiac devices, prosthetic valves and intravascular stent, and another thing, contrast agents which cannot be used in kidney disease patients. So conclusion of this is that it is a close call where two heavy weights like PET and MR slug it out in a battle to the finish. But according to Dr. Johann Christopher opinion, MRI is the clear winner as it is easily available. But I tell most of the institutes which have MRI at present nowadays, if it is a cardiology institute, they have PET also, SPECT also. So our modalities is also easily available at present, cheaper. I think PET also is cheaper. We do PET CT for 5,000 rupees, cardiac PET CT. So it is also cheaper, more reproducible, and simpler logistic with shorter procedure. Like PET we can do in 10 minutes. So that is also a very short timing. So, but imaging beyond viability, that is the main thing which can be seen in MRI. But in PET only we tell whether it is viable or not, and we are not doing gating also in PET. So that is the thing. So as we know, we always talk about debate and other thing, but we are friends, like PET MRI is available. So this is the study which showed they both are complementary. So MRI and PET are complementary in everything. So hybrid PET MR is the future. So this is the summary, like PET, SPECT uses membrane integrity, PET uses glucose metabolism. So what is the take home message? SPECT is sestamib, which is used in ischemia and viability, and FDG is used in hibernating myocardium. As we talk, still it is controversial whether it is viability is useful in revascularization. Wherever, but I tell wherever PET and PET SPECT is available, you can use it and you can compare with CMR and do studies like how it is useful to see the hibernating myocardium and revascularization. And another thing, as we tell, it is difficult, but according to me, PET is easy to perform, and we also see wall motion LVEF and give some like evidence to of wall motion abnormality and EF also with the help of SPECT and PET. Thank you.
That was an excellent presentation, Dr. Kamlesh.
Thank you.
Any questions from the audience?
No, I think, yeah.
Very nice presentation as usual. Practical point, if a patient is referred for ischemia and viability, you start with SPECT.
We do stress imaging, sir. If
Yeah.
patient EF is normal, we go for stress imaging.
Yeah.
Then we see is there any perfusion defect, like we score this whether it is totally absent or reduced. So if completely absent, then it won't reverse. So there won't be ischemia in that. So those areas which are completely absent perfusion and not reversing, then we go for FDG viability
Yeah,
study.
so my question is, because you have to give insulin and glucose loading for FDG,
Yeah.
how does it practically happen? Because your SPECT itself will take
Yeah, I'll-
4
I'll-
hours, 8 hours. So how
No, sir, no, sir.
if you do both stress rest together?
Yeah, both stress and rest, if you do, then it will take, like morning in our department, 9 o'clock, we call the patient for SPECT. We do treadmill or adenosine. We have stopped completely dobutamine. So we do stress, 10 to 15 minutes treadmill. Then we ask the patient to go and have food and come back. Then imaging will be done after 45 minutes to 1 hour. So 15 minutes imaging. Immediately we inject rest. We finish stress and rest by 11 to 12 o'clock.
Okay.
We finish by 12 o'clock, and if FDG is available, we are getting 2 doses. Afternoon 1 dose will come. So if patient is fasting, then same day we give the glucose and insulin loading, and we can do FDG by 2 o'clock. It is possible to do on the same day. It is not not
Is
possible.
that your normal practice?
Yes, sir. But nowadays, actually, our cardiologist, previously we were doing PET for viability assessment. Now, at present, our cardiologist in KMCH says if SPECT is not showing uptake, then don't go for FDG viability. You give it as non-viable. So that is the thing now it is happening. So at present, only like if you do 10 cases, only one is coming for FDG viability. I think because of these trials, now cardiologists are thinking that viability assessment is not useful very much.
Whenever we see a patient with severe LV dysfunction, we always have a dilemma whether to send the patient to nuclear scan or MRI. But it's always better that we get a viability scan before revascularizing any patient with severe LV dysfunction.
Yeah.
And it's helpful for prognostication as well as long-term outcome.
Yeah, thank you.